Someone has paid thousands of kwachas to buy, especially the young who are not understanding the disease. They are dependent on the help from the parents. But once you're an adult like me, I can control on my own. And once you control, it's straightforward. Your meal, you know, you have to sugar is wachefya kwa kabwani. Not because in Sima there is chicken attire na ionera kutirero. You enjoy your good meal, but again you go into hyperglycemia.
So when do you ask the patient to come back for refraction?
For refraction,
until
you do a refraction when the sugar level is stabilized. You cannot do a refraction when their sugar level is above the normal.
So which one is normal? And when is the abnormal? And when is the less?
It is the normal. I think I would say 10 millimoles is reasonable. You know? Immediately you start going to 15, 20, when you check your sugars, it's too much. Or if you, it's also going to hypo, it's not good enough. So the whole thing is a balancing act. A balancing act to avoid elevated sugar levels. And you can tell that you've got elevated sugar levels. For example, with so much hyperglycemia, your vision will be blurred because the vitreous is full of glucose.
So is there any other short management that you can give to a diabetic patient? Since you want to refract them.
No, they have to be refracted.
If the levels, the sugar levels
yes, if the sugar
high,
okay, no, there's no need. Yeah.
Can you give any eye drops or something?
No, eye drops is nothing. It's the sugar control. It's the sugar you are trying to control, not eye drops.
What of those who go to the pharmacy, then they give them something?
Look, how to control the sugar levels? There are two ways. You can give tablets, metformin, or you can give insulin injections. They'll be on insulin. You understand? But at the end of the day, whatever treatment you are giving must be accompanied by regular glucose check, what they call fasting blood sugar, FBS, must be there. Whatever treatment you are giving, in the morning, they should not be hypoglycemic. Okay, the levels will come down, but not where they are now sweating because of hypoglycemia. It's a balancing act. Even those who are on metformin, they can go into coma because of hypoglycemia. And if you don't control again the high blood sugar, they can still go into coma, hypoglycemic coma. It's not a pleasant disease. That's the shortcut. But if you've got food, you just have to control yourself how much you eat. Many people have done it. So far, I'm trying my best. Yes. It doesn't mean you can't eat chocolate. You can eat chocolate. You know, I've reached a stage where, no, today I want a chocolate. I'll go and buy and eat. Following day, but I will know I will reduce other carbohydrate intakes. In the morning, the fasting blood sugar will be my witness, whether the levels are okay or not. Diabetes is difficult for children because they don't understand all these things I'm talking about. They have to rely on their parents to do it. That's where the problem is. But if they are adults, you can talk to them. They will understand. It's a nasty disease for children. They don't understand. They don't understand. The child goes, Pamiru likes this meal today, it's a big chicken for me. I know, take a kudia. But for you and me, we understand that you can't overeat. But you don't have to starve yourself equally. There's no harm once in a while you will find a good meal has come on the table. You can eat. But the best way to after eating, you have to adjust your intake of medication. I do that myself, and somehow I get away. It's a difficult disease, difficult especially to the children, because children, to put them on injections, they will hurt you as a parent. They will hurt you. It's like punishment for them, but you are trying to treat them. Hello, those are diseases. Okay? No, na treated now I'm okay.
So where do they do the is it
sugar level?
The imaging, talking of the photocoagulation. Photocoagulation, is it imaging? The fantasy imaging and all those.
Oh, where they do?
Locally.
Oh, here in Lusaka. I think UTH should have all those facilities. So Center for Excellence. I'm not sure about Manawasa. They could also have. Okay? I will need to check. But UTH should have. Kito Central Hospital has got most of the facilities. And I'm not sure about Lusaka. I was for this at the Seventh-day Adventist Church. Lusaka, there's an eye hospital there also. They may have also. They may have. UTH, I think they have. It's a Center of Excellence for ophthalmology. They have, I think. Still 10 minutes, eh?
We have some more time.
Okay.
But out of questions, they are not responding.
Oh, me?
Our friends here.
Oh, the questions, they've run out of questions. No, it's a difficult disease, but it's not impossible. You and me, because we are adults, we understand the value of our life. We want to live a bit more. But for children, if you have a child, it's very difficult to incorporate that child in the family. A lot, doesn't understand that if you eat too much, you are going to be in problems, medically. So those have to be under parental control.
And how does hypoxia also come in the
hypoxia?
In the pathogenesis.
Where does it say hypoxia?
Somewhere where I read.
Here, we are here. Show me where.
Okay.
Not where you read. Just go Pama slides.
Yeah, is it the first slide we had?
Put there so that we all see where you read.
Okay, there's a question for Malambo here. What happens when one has cataract and diabetes retinopathy?
Yes, what happens?
Which condition do you first treat?
Obviously, it's cataract.
If it is a matured cataract.
It's a cataract. Straightforward. You will not see the retina if there is a cataract. That's the bottom line. Treat the cataract. You can give them an implant, artificial eye or intraocular lens. You will still be able to see the fundus. Obviously, it's the cataract first. Must be treated. Okay, having said that, medically you have to treat the diabetes so that they are under control nicely. But the way forward is you have to do a cataract operation so that you see any growth of any growth of blood vessels, new vessels on the retina. Those are treated by laser. No, cataract, if it's there, it has to come out. Because you won't see the back of the eye. Even if you can't just put them on medication. You put them on medication, but there must be a stage where cataract must come out. The earlier, the better.
So my question was coming from here about the hypoxia.
Why? Okay, the above feature lead to, what is this topic first?
It's a pathogenesis.
Pathogenesis for diabetic retinopathy, microangiopathy, precapillary arterioles, capillaries and venues, retinopathy features. Where are you? Retinopathy features. Microvascular occlusion, microvascular leakage. You remember I was talking about those capillaries where the wall is weak. You have protrusions of the endothelial layer through those holes. Those are the ones which give you the dot and blot, dots like that. Bleeding,
Then we go here.
Which one? Red blood cell changes leading to defective oxygen transport. Increased platelet thickness leading to aggregation. Yeah, okay, this, for example, red blood cell changes leading. It can't change. You don't put diabetics on oxygen unless they are gasping like me. The solution to diabetes is to control the sugar levels. After controlling the sugar, this control has to be in conjunction with how much you are eating, how much the patient is eating. It can just not, it's not about giving tablets, giving insulin from 10 years up to control. The patient hasn't yet eaten, and the patient must eat. So it's a balance. The patient needs to eat. At the same time, leaving the sugar levels in a reasonable level, reasonable. And as I said, it's more difficult in the children who don't understand what is happening. He's seeing his fellow brothers and sisters, they are eating, hallelujah. He might know where very difficult. But for an adult like you and me, we know if I don't do nice things, I may not see tomorrow. I may not see tomorrow. Talk about, no, this man is an old man, he doesn't want to live it tomorrow. Everyone wants to live it tomorrow. Isn't it? Yes. It's a control, it's the more difficult. That's why my parents in the diabetes, it's a very, very big burden, which needs support from both the father and the mother of that child. Not walishira ba madam wati no kali walisha tumana alirwala yole jaiva mumapa. No good. No good. It's a big problem in homes,
Someone was asking, say, does diabetic retinopathy cause pain?
No, there's no pain. There's no pain.
Then another question, say, can someone with diabetic retinopathy drive?
I like that one. Is she? You say she, is it? The one who was asking. You can drive, me, I drive. But I don't have diabetic retinopathy. It's under control. No, driving has got standards, to be very honest. Driving has got standards. You go there, they check your eyes, isn't it? Vision. If your vision is low, they may not give you a license. Driving has standards. But if you've got a good sight, you can drive whether you're diabetic or not. You have good sight today, you're a diabetic, you can still drive. I drive myself. But look, my sugar levels is within normal. I control at the same time.
Two questions.
Yes.
Can a person with diabetes type 1,
Type 1, yes.
which is insulin,
Dependent.
die when they miss the prescribed time for the injection? That's the question.
I don't know when God has decided that someone must die. No, it's not like you have missed, you die. There are a lot of factors. The ideal is take your medication regularly. Injections, don't overdose yourself. You will go into hypoglycemia and you pack up. Understand?
So another concern. There was a patient who was diagnosed with unilateral cataract, but he was told that they cannot do the surgery because the sugar levels
are high.
Maybe you explain on that one. Why?
Yes, because to do surgery, first you have to control the sugar levels. Whether diabetic or it's something they find one off, your sugar levels is through the roof. No surgeon will agree to go to operate. But it will be a problem in theater with the anesthetist. Giving you the gases that you need to be operated and looking again on the sugar levels.
So what's the clinical significance?
If a patient who is diabetic is going to go to theater, the diabetes should be controlled. Sugar should be controlled. They can't go there with very high sugar levels. No.
What may happen?
They will go into coma.
Okay.
They'll go into coma. So sugar level is part and parcel. I'm sure you know that when they're pre-operative, isn't it routine that they check the HB, they check the sugar, blood sugar? They do, isn't it? Yes. That's why they check. They don't want to have an occasional diabetes patient who has been missed, only to be discovered on the operating theater. No, anesthetists don't want that. No one wants that. Because once that is discovered, they will tell you first to catch the controlled diabetes before you can go to theater. That's the first thing. They might also decide we want under local instead of under GA.
So another question. But how quickly does diabetic retinopathy progress?
It's $1 billion question. Progression of disease, you can't put a figure that progression diabetic retinopathy will depend on the control which is prevailing in that patient. If it is controlling, it doesn't mean it will not progress. It will progress, but at a slower rate than those who are not controlling their diabetes, their sugar. Diabetic retinopathy will be at a higher rate growth. So those are some of the factors you see. If someone understands, is nicely doing things, it doesn't mean he will not have. He will have, but after a long period. But if he's a champion for everything, he knows everything, Mr. Know-it-all, you end up having diabetes, blood vessels growing quickly, fast. But it doesn't control his sugar.
Then say another one, can type 2 diabetes cause blurred vision?
Yes, it does. High levels of sugar in the vitreous causes blurred vision. One of the signs you can see, check your sugar. Especially people who are diabetic, they are out doing other things in, bali out mukupanga fimbi, bali labano kusenda omuti, kula kwine kuti yabekata. Because this control is the intake of food you take and versus the medication you take. If that cycle is broken down, my friend, your sugar levels can go up, or you're taking too much medication over the prescribed levels, your sugar levels will go almost zero. You go into hypoglycemia, hypoglycemic coma.
Then another one. Can metformin improve vision?
What does she mean by is she? Am I right? No. Yes. Okay. You get my answer.
No and yes.
No and yes. Yes, metformin controls, helps people to control those who are on a non-insulin dependent diabetes. They take metformin. I do personally, I take metformin. And I have no problem. All I do, I balance the taking of metformin with my sugar levels, fasting blood sugar. If it's within the levels, it means I'm at a correct level and my eating is okay. So the question was what? Can metformin?
Where is that one?
You're asking,
Can metformin improve vision?
Yes, it can improve vision. For a patient who doesn't know they have diabetes, they are not taking any medication, they will come with poor vision. You check the blood sugar, it's the sugar that they have. That's the problem. It's not everyone you are going to put on injectables. You see the point? They can start on metformin. And once they come to stabilize, the sugar, the vision will be perfect. I am a driver, I drive, I take metformin every day, no problem.
Seems we have no more questions. Participants are few.
Okay. So thank you very much, ladies and gentlemen. Tomorrow we'll see what we can do. I hope things have been cleared here and there, no? Because the treatment for diabetes is not to cure, it's to control the sugar levels. You control through medication and eating. Now, your eating should not be regimented. No. It's a human being. Today, maybe there is some relish you've been crying for. Finish. That's how it works.
And can glucose control in patients with diabetes?
Can glucose control?
In patients with
patients.
Can glucose control in patients with diabetes prevent the onset of retinopathy?
Delays, not prevent. You understand? You're going to find the textbooks. It's delayed the onset of diabetic retinopathy, features of diabetic retinopathy on the retina, for example. So the more you are controlled, the more you stay with clear retina.
And how does the hyperglycemia regulate the progression of retinopathy?
Progression of retinopathy, you are not controlling the sugar levels. The whole disease process is about sugar levels. Hyperglycemia is normally controlled with medication. If you are not taking that, you are not aware that a lot of people sometimes are not aware. They are not taking that. It goes with full-blown diabetes with new vessels formation. Once the new vessels have come, they will not be controlled by metformin or by drugs. Understand? Once the new vessels are there, it's not medication which will control the vessels. Those have to be cleared with laser, like that. Then the medication is to avoid again regenerating some more new vessels.
So, thank you very much, sir. Diabetes has been well explained.
Thank you.
From Madam.
No, Madam. Karumbwana. Mwalia. My doctor friends, they always say, Ashonto. I said, you guys, what is Ashonto? I said, no, doctor. If you say Nariama Ningi, they will not give you. I kind of we have written a lot. So a Tonga, I have a lot of Tonga friends. Even if you come from eating, Mwadia, you say Ashon.